These are the steps of the discogram with double C-arm in the inspired spine. And as you see, patient is in prone, and we prep and drape it in sterile fashion. We use two C-arm, one in the lateral position that goes over the head, and the other one AP that it comes perpendicular to, at 45 degree to the bed. Now here I'm going to speed it up a little and show you that the material that we need is really minimal. We do the prep after the lateral machine is placed, and that enables us more in the direction of having a sterile filled properly. By the way, this is the same way we prep and prepare the olive. And first we put the down sheet, then we, as you have seen, we cover the part of the lateral C-arm that goes over the patient. And now I'm going to speed up a little. You see that the AP machine is being prepared, but we will prepare it, drape it before it comes in. As well, I want you to pay attention that this preparation is done usually within just few minutes. Now I want you to see as well things that we need for the procedure itself. Everything that you see on the right side of the table is all what we need for the procedure. I'm going to mark it for you. So all what you see there is what's needed. Now here, after 3 minutes is over, we put the actual drape, and I'm going to speed up. I'm waiting for the time, and as you see, we put it in and we spread it and we pull it over the machine. That gives us a very easy to follow steps that enable us literally prep and drape everything within 5 minutes or less. AP machine is now covered. It comes at 45 degree and we are ready to go. As you see here, we first bring the AP machine in. We first get a good lateral picture, so we see the proper edges of the bone in the area that we are going to do the discogram. We identify the landmarks, draw radiographical midline, and as well trajectory of the disc as you see here. Then we as well identify the trajectory that takes us to actual disc. And here we are at 15 minutes after this video has been started to record, and we are actually going to start now, after the timeout, the actual procedure. I inject some local anesthetic in the area that I'm going to enter. Here now the needle goes in and the discogram starts actually at this point itself. As you see, I put a very strong bend in the tip of the needle, and then we are able to just direct it on the AP and lateral. Well, you don't see the AP view here. Our C-arm wasn't working, but practically by having two C-arm in the AP and lateral, I'm able to direct it without moving the position of the C-arms in the direction of the disc and aim for the lower part of the disc. Once we are there, we are able to enter it inside of the disc quite efficiently. As you see here, we are entering the disc in the L3-4. Now, practically I'm going to, same fashion, numb up the skin and do the same thing for the other two levels. We started the actual discogram, as you see here, around minute 19 or 18, and I'm able now to put the second needle in, and again follow the trajectory under AP and lateral to the bottom part of the disc, just above the pedicle of the level of below. And once I have a good position in the AP and lateral, I enter the disc. 5S1 is always more difficult for multiple reasons, and here you see that I'm able to go actually farther up and not come at an angle that guides me under the iliac crest. In the AP, you will see your clearance from the iliac crest. For 5S1, sometimes as well I use the trajectory that take me through the lamina and penetrate the dura twice, practically a transdural approach. For that, it's always a good idea to put the AP so you get an orthogonal view of the L5S1 disc. But here I'm able to go in, and initially I put my needle in, but I'm not really happy with that. So, and once I put the contrast, I'm able to see that I'm not completely through the capsule. I'm going to speed it up. In the second pass, I'm able to put that in, and now you see that when I'm putting the contrast in, I'm having full entry of the contrast inside of the disc. So in the AP as well, obviously we get a good information. We record, first of all, how much resistance do you need to put contrast in. Certainly you can have the PSI number, which a normal disc should tolerate up to 70, 80, even 90 psi. A bad disc usually at 15 to 25 psi start causing pain because of the extrusion of the contrast. I use only high and medium and low compliance, and then the number of the level, the amount of the contrast, and level of the pain, and if it is concordant or not. The concordance, it's about the location of the pain generated and not about the quality or other characteristic of the pain. Here you see that there's a little bit of a leakage, but most of the contrast stays in. So in the 5S1 we had 10 out of 10 concordant pain with contrast extrusion and pathologic morphology. In 4-5 we had semi-pathologic morphology with some extrusion and non-concordant high-level pain. And in L3-4, which was our control level, no pain was provoked. And as you see in a good disc, you see the entire contrast is inside, and sometimes you see the so-called hamburger sign, where the contrast goes around the nucleus pulposus, and you see contrast that practically bordering nucleus pulposus. And I'm hoping that you will see that here upon the injection here clearly. I'm going to speed it up, and here you see that the contrast goes entire nucleus pulposus, meaning that this disc is not in the best shape, but still contrast stays in. In a very good disc, a normal disc, you see that the contrast goes and encapsulate the nucleus pulposus. And this discogram proved that the patient's clinical symptom coming from L5S1, which I will discuss with the patient what the next step of management of that would be. So practically I'm done here. We started the discogram for this 3 level at 18 minutes, and on 26, meaning 8 minutes later, we are done with the discogram. So the two CRM make it very efficient to perform a discogram.